Hi, today I will be talking about the clinical practice guidelines for the evaluation and management of acute pulmonary embolism in adults, a report from the American College of Cardiology and American Heart Association. American College of Cardiology and American Heart Association class of recommendation and level of evidence. Class 1, which is a strong recommendation where the benefits far outweigh the risks. Class 2A, which is a moderate recommendation where the benefits outweigh the risks. Class 2B, which is a weak recommendation where the benefit slightly outweigh the risk. Class 3 recommendation where there is no benefit or there could be harm when the risks outweigh the benefit. Level A evidence is high quality evidence from more than one randomized controlled trial. Level B R is a moderate quality evidence from one randomized controlled trial. Level B NR is moderate quality evidence from one or more non-randomized studies. Level C is evidence from consensus of expert opinion. Clinical evaluation of patients with suspected acute pulmonary embolism. Perform target history and physical to assess clinical probability of acute pulmonary embolism. Quantify clinical probability of acute pulmonary embolism using a validated tool such as Wells score for PE and PE rule-out criteria, which will be discussed in the next slide. If the clinical probability is less than 15%, which is considered low, assess PE rule-out criteria, and if all criteria are met, it is considered as very low clinical probability for PE and no further diagnostic testing is needed. If the clinical probability is greater than 50%, which is considered high, perform a diagnostic testing. If the clinical probability is between 15 and 50%, which is considered as intermediate, perform D-dimer testing and assess the EARS criteria. EARS criteria includes clinical signs of DVT, hemoptysis, and PE. If the EARS criteria is 0 and D-dimer is less than 1000 nanograms per ml, pulmonary embolism diagnosis is excluded. If there is greater than 1 EARS criteria and the D-dimer is less than 500 nanograms per ml, pulmonary embolism diagnosis is excluded. If the EARS criteria is 0 and the D-dimer is greater than 1000 nanograms per ml, perform diagnostic testing. If EARS criteria is greater than 1 and D-dimer is greater than 500 nanograms per ml, perform diagnostic imaging. Clinical pretest probability by Wells score. Components: clinical symptoms of DVT, 3 points. PE more likely than other diagnoses, 3 points. Heart rate greater than 100 beats per minute, 1.5 points. Immobilization greater than 3 days or surgery in the prior 4 weeks, 1.5 points. Previous history of DVT or PE, 1.5 points. Hemoptysis, 1 point. History of cancer, 1 point. If the Wells score is less than 2, then it's a low pretest probability. If the Wells score is between 2 and 6, then it's a moderate pretest probability. And if the score is greater than 6, there's a high pretest probability. Pulmonary embolism rule-out criteria. Components: age less than 50 years, heart rate less than 100 beats per minute, oxyhemoglobin saturation greater than 95%, no hemoptysis, no estrogen use, no prior history of DVT or PE, no leg swelling, no surgery requiring hospitalization in the last 4 weeks. When all the criteria are met, the likelihood of PE is low and no further testing is required. Diagnostic testing. In patients presenting with symptoms and signs suggestive of an acute pulmonary embolism, imaging is recommended for those who have high pretest clinical probability of PE. In patients undergoing imaging, a positive CT pulmonary angiogram or high probability ventilation perfusion scan is sufficient to diagnose PE. In patients undergoing imaging, CT pulmonary angiogram is recommended over a VQ scan to confirm the diagnosis of acute PE. In patients undergoing imaging for PE, VQ single photon emission computed tomography scan is reasonable over a planar VQ scan. In patients who cannot undergo CT pulmonary angiogram, it is reasonable to perform a VQ scan. In patients with suspected acute pulmonary embolism, echocardiogram is not recommended to confirm or rule out the diagnosis of PE. Acute pulmonary embolism clinical categories. Category A. Patients in this category are asymptomatic and have incidental diagnosis of PE. Category B. Patients in this category are symptomatic and have low clinical severity score. Example, pulmonary embolism severity index less than 85. Subcategory B1 consists of single or multiple subsegmental pulmonary embolism. Subcategory B2 consists of non-subsegmental PE. Category C. Patients in this category are symptomatic and have elevated clinical severity score. Example, pulmonary embolism severity index greater than 85. There are three subcategories. C1 consists of normal right ventricular function and normal biomarkers. C2 abnormal right ventricular function or greater than 1 abnormal biomarker. C3 abnormal right ventricular function and greater than 1 abnormal biomarker. Biomarkers include elevated cardiac troponin I and elevated brain type natriuretic peptide. Category D. Incipient cardiopulmonary failure. Subcategory D1 consists of patients with transient hypotension. Subcategory D2 consists of patients having normotensive shock, which is defined as isolated hypoperfusion resulting in end organ damage, example acute kidney injury, without hypotension. Category E is the most severe category. Patients in this category have cardiopulmonary failure. Subcategory E1, patients have recurrent or persistent hypotension with cardiogenic shock. Subcategory E2, patients have refractory cardiogenic shock. Example, patients diagnosed with saddle pulmonary embolism who are on mechanical ventilation and have severe right ventricular hypokinesis on the echocardiogram and hypotension requiring multiple vasopressors. Pulmonary embolism severity index risk score components include age, male gender 10 points, history of cancer 30 points, history of heart failure 10 points, chronic lung disease 10 points, heart rate greater than 110 beats per minute 20 points, systolic blood pressure less than 100 mmHg 30 points, respiratory rate greater than 30 beats per minute 20 points, temperature less than 36 degrees Celsius 20 points, altered mental status 60 points, oxygen saturation less than 90% 20 points, class 1 lowest risk less than 65 points, class 2 66 to 85 points, class 3 86 to 105 points, class 4 106 to 125 points, class 5 highest risk with greater than 126 points. Markers in patients with acute PE and elevated clinical severity score without hypotension or shock, i.e. category C. Measurement of cardiac biomarkers such as troponin I and brain natriuretic peptide is recommended to assist with risk stratification. In patients with acute PE category C to E, measurement of lactate is recommended to assist with risk stratification. There is 9-fold higher risk of PE-related mortality in patients with elevated lactate. Right ventricular imaging in patients with acute PE and elevated clinical severity score but without evidence of shock, i.e. category C and D. Right ventricular imaging is recommended for risk stratification. Right ventricular hypokinesis is associated with a 4-fold increased risk of PE-related mortality. Pulmonary embolism response team in patients with acute pulmonary embolism who are at increased risk of adverse outcomes categories C through E. A multidisciplinary PERT assessment is recommended to improve clinical outcomes. It is a class 1 recommendation. Pulmonary embolism response team can comprise of emergency medicine physician, intervention cardiologist, vascular surgeon, radiologist, intervention radiologist, cardiothoracic surgeon, pulmonary and critical care physician, pharmacist, and nursing staff. Anticoagulation therapy. Patients with acute pulmonary embolism who do not have any absolute contraindication to anticoagulation, it should be initiated to reduce the risk of recurrent venous thromboembolism. Patients with acute pulmonary embolism category A and B, it is recommended to start direct oral anticoagulants over vitamin K antagonists. Patients with acute pulmonary embolism category C1 through E1, low molecular weight heparin is recommended over unfractionated heparin. Patients with acute pulmonary embolism and thrombotic antiphospholipid antibody syndrome, a vitamin K antagonist such as warfarin is recommended over direct oral anticoagulants for prevention of venous and arterial thrombosis. Patients with mild to moderate chronic kidney disease stage 2 and 3, a direct oral anticoagulant is recommended over vitamin K antagonist to reduce major bleeding. In patients with severe kidney disease stage 4 and 5 or end-stage kidney disease on hemodialysis and confirmed pulmonary embolism, it is uncertain whether apixaban is better than vitamin K antagonist to reduce bleeding. Patients who are pregnant and have acute pulmonary embolism, either low molecular weight heparin or unfractionated heparin are recommended. Direct oral anticoagulants and warfarin are potentially harmful and may result in miscarriage or fetal anomaly. Patients with chronic liver disease with acute pulmonary embolism, Child-Pugh class A, direct oral anticoagulants over vitamin K antagonist is reasonable to reduce bleeding. Child-Pugh class B, treatment with a direct oral anticoagulant over vitamin K antagonist may be reasonable to reduce bleeding. Child-Pugh class C, direct oral anticoagulants are not recommended. Initial assessment and management of acute pulmonary embolism clinical categories. Category A and Category B. Initiate direct oral anticoagulants and manage as an outpatient. This is a class 1 recommendation. Initiate low molecular weight heparin for category C1 through E1. This is a class 1 recommendation. For category E2, initiate low molecular weight heparin or unfractionated heparin. It is a class 1 recommendation. For category C1 through C3, measure at least one cardiac biomarker, which can be troponin I or brain natriuretic peptide. It is a class 1 recommendation. Measuring serum lactate is a class 1 recommendation for category C1 through category E2. Evaluating right ventricular size and function by an echocardiogram is a class 1 recommendation for category C1 through category E1. Use validated risk score to identify high-risk patient for category C1 through C3. It's a class 2A recommendation. Hemodynamic pharmacotherapy, patients with acute pulmonary embolism in categories D2 through E2, those with cardiogenic shock. Initiate vasopressor and or inotropic therapy. It is a class 1 recommendation. Systemic thrombolysis in patients with acute pulmonary embolism, categories E1, E2, and acceptable bleeding risk. Systemic thrombolysis and anticoagulation is reasonable over anticoagulation alone to reduce mortality and recurrent P. In patients with acute pulmonary embolism, categories D1 and D2, and acceptable bleeding risk, systemic thrombolysis and anticoagulation may be considered over anticoagulation alone. In patients with acute pulmonary embolism, category C3, and acceptable bleeding risk, the use of systemic thrombolysis and anticoagulation over anticoagulation alone is uncertain. In patients with acute pulmonary embolism category A through C2, systemic thrombolysis should not be used over anticoagulation alone. Catheter-directed thrombolysis. In patients with acute pulmonary embolism, categories E1, catheter-directed thrombolysis plus anticoagulation is reasonable, and categories D1 and D2, catheter-directed thrombolysis plus anticoagulation may be considered to prevent further clinical deterioration and mortality. In patients with acute pulmonary embolism, categories C2, C3, the benefit of catheter-directed thrombolysis plus anticoagulation is unclear. In patients with acute pulmonary embolism, categories A through C1, catheter-directed thrombolysis is not recommended over anticoagulation alone. Mechanical thrombectomy. In patients with acute pulmonary embolism, category E1, mechanical thrombectomy plus anticoagulation over anticoagulation alone is reasonable. Categories D1 and D2, mechanical thrombectomy plus anticoagulation over anticoagulation alone may be considered to prevent further clinical deterioration. In patients with acute pulmonary embolism, categories A through C1, mechanical thrombectomy is not recommended over anticoagulation alone. In patients with acute pulmonary embolism, categories C2, C3, the benefit of mechanical thrombectomy plus anticoagulation is unclear. Surgical embolectomy. In patients with acute pulmonary embolism, category E1, surgical embolectomy compared with anticoagulation alone is reasonable, and categories D1, D2, surgical embolectomy plus anticoagulation may be considered to prevent further clinical deterioration. In patients with acute pulmonary embolism, categories A through C3, surgical embolectomy is not recommended. Anticoagulation therapy. In patients with first episode of acute pulmonary embolism and no major reversible risk factors, continuing anticoagulation beyond the initial treatment phase, which is 3 to 6 months, is beneficial to prevent recurrent venous thromboembolism. In patients with first episode of acute pulmonary embolism due to a major reversible risk factor, stopping anticoagulation at the end of the initial treatment phase, which is 3 to 6 months, is recommended. In patients with first episode of acute pulmonary embolism due to persistent risk factors, continuing anticoagulation at the end of the initial treatment phase, 3 to 6 months, into the extended treatment phase is reasonable. In patients with acute pulmonary embolism who require anticoagulation beyond the initial treatment phase into the extended phase, treatment with direct oral anticoagulants is recommended over vitamin K antagonists. In patients with acute pulmonary embolism and with history of cancer who require anticoagulation beyond the initial treatment phase, which is 3 to 6 months, either direct oral anticoagulants or low molecular weight heparin is recommended over vitamin K antagonist. Risk factors for venous thromboembolism. Major reversible risk factors include surgery with general anesthesia lasting more than 30 minutes, hospitalization for acute medical illness lasting more than 72 hours, cesarean section, and lower limb fracture. Minor reversible risk factors include surgery with general anesthesia lasting less than 30 minutes, hospitalization for acute medical illness lasting less than 72 hours, out of hospital acute medical illness lasting more than 72 hours while confined to bed, trauma with decreased mobility for more than 72 hours, peripartum period, persistent risk factors, active cancer with or without ongoing treatment, autoimmune diseases such as rheumatoid arthritis, systemic lupus erythematosus, inflammatory bowel disease,